Board.
So we have to type our name in the chat now?
Yes, please. Yep.
Okay, thank you.
You're welcome. I just started recording. Can anybody hear the fan in the background for me? And if so, is that distracting?
Nope.
No, you can't hear it, or no, it's not distracting?
No, can't hear either.
Oh, so,
Is that the wind tunnel sound?
what?
I'm just kidding. I'm messing.
The wind channel. I've just been up on my roof trying to get the swamp cooler working, and it is. Oh, you guys just left Pete's. Okay, you guys want to go take a quick 5-minute break, get something to drink, go to the restroom? It's up to you. Or you want to get going?
I have a question.
Yep.
Okay, so I was trying to get in the exam tutorial at 7, but
you were trying to get. I'm sorry, I can't. Can you put the camera down on your face so I can see you? I'm just kind of looking at the ceiling. There we go. Okay, what now? Hi, Stephen.
Okay, hi. So about the exams tutorial.
The exam reviews?
Right.
Okay.
But I couldn't get the code because there was there was one schedule at 7 p.m. before this class.
I'm sorry, I'm not understanding. Do you mean the schedule I sent out this week with review times every day?
Yes.
Okay.
The
Let's look
ID
at that.
for the ID.
Hang on, let's. This one, Stephen?
Yes, ma'am.
Okay, what about it now?
So, I mean, the ID to get in.
Oh, it's the same Zoom link as class. I use this for everything.
Yeah, I tried the same thing, but like I couldn't get in.
Well, because we hadn't scheduled anything and I wasn't on Zoom. You have to, I said in the announcement, please let me know what your preference is. And so nobody signed up. I did have somebody sign up for today.
Oh, yeah, my bad.
That's okay.
I have to sign up first.
Yeah, no
Okay.
worries. You have to sign up or just shoot me an email and say, I want this time.
Okay, all right, thank you.
Okay. I have one review tomorrow, not review, but it's with another class, but the only person I had respond was somebody that responded maybe like an hour ago and I didn't see it. So I'd have to go back and look and see who that person was. They wanted an hour ago, so I missed that. Anyway, so I'll get with that student, but I haven't had anybody other than that one student sign up for any reviews. I don't know what to tell you. I mean, it's not mandatory, but it's highly recommended if you got below an 80. So hang on, I'm going to stop sharing, make sure everybody's here. Everybody put their name in the chat, please. That's how I'm taking attendance going forward. Please. And I didn't hear from anybody today that they weren't going to be in class. So anyway, put your name in the chat. But yeah, I haven't heard from, first of all, hi, how are you? How's everybody from Monday night? Everybody have a nice weekend. Yes. Okay. So, oh, I'm sorry. Go ahead.
The thing that you were talking about to sign up for the exam, where is that? Is that in the announcements or something?
Yeah, I posted it. I posted it last night. Right here.
Oh wow, I've never seen that.
Okay, it's right here, and I have days well, today's gone past, but I have time Tuesday, one Wednesday, and some Friday. I'm a little bit limited this week. This is the best I could do. There were 10 options. I'm covering for, I teach 3 classes in the PN program, and I'm covering for an instructor who's on vacation. So I've got all of her classes. So I'm a little bit tight this week, but we'll see who wants to sign up. I'm not going to go further if people aren't signing up. I mean, I can do next weekend, but you know, I'm hoping that, you know, and you know what, if you want to sign up and none of these times work for you because of school and clinicals, then I'm happy to try and schedule something with you one-on-one. But I'm just, well, I'm making the initial assumption that nobody got back to me because they didn't want to maybe review the exam. I don't know. I mean, how are you guys feeling about that? I'm open to review with anybody below 80, which I think, you know, I highly recommend. Above 80, I mean, I have students that I tutor or that I review the exam that get in the 90s. They want to know the 2, 3, 4 questions they got wrong. So it's open to everybody. What's your, I mean, be honest here. What's your initial thought? Did everybody see that email last night?
No, I didn't see it, but I wasn't home last night.
Okay. Did anybody else see the email last night or during the day today? Does anybody
saw it today?
Okay. Does anybody have any desire to review the exam other than Stephen at this point? Today. Juliana, are you the one that sent me an email an hour ago or a couple hours ago? Okay. Okay.
I would like to review it with you. I just didn't see exactly the times that were listed. I have clinicals all day Wednesday. I think that you had Wednesday time posted. Is that correct?
I just had one on Wednesday. I had several tomorrow and several Friday.
Okay. Yes, I will email you then about tomorrow. We had PEDS exam today, so.
Yeah, no worries. No
worries. Get through one exam before the other.
Absolutely. Absolutely. I understand. I mean, overall, you guys did okay. I mean, didn't have a lot of high scores, didn't have a whole lot of low scores, had, you know, a lot of kind of mid-range scores. But again, I thought you, as a whole, I just always worry about the first exam because you get behind the 8 ball and you're working all term to catch up. So I don't really have that feeling with this class. I think, you know, the midpoint was, it was higher than usual for my terms. So, you know, for all of you that got in the 70s, whether it was a 72 or a 78, I mean, that's okay for exam 1. We just have to work harder for exam 2 and 3. And that's why I really want to review the exams with you and go over what you missed. Because remember, everything's cumulative. I mean, exam 2 covers weeks 3, 4, and 5, not 1 and 2, but at the end, the Hesse covers everything. Couple of things, the Hesse study guide is being worked on as we speak. Hopefully we'll have that to you by the end of the week. And that's just kind of a long-term planning. It goes through, we have reviewed previous Hesses and listed out what topics were on the exam. So it's actually a really good study guide. Obviously we don't know what the questions are in Hesse. We create the exams internally, but the Hesse is like NCLEX. They pull from a big bank of 1,000 questions. So all we can do is help identify the topics that were covered. Does that make sense? So that's coming. We're actually updating it a little bit based on some recent Hesses. So that's great. The other document that's being worked on is study guide for exam 2. Okay, hopefully we'll have that in the next couple of days to you. We're covering weeks 3 and 4 this week, correct? from everyone from Jen. 4-4. I don't know what that is, Jen. Jen, do you want to clarify the chat?
My dog stepped on the computer. Sorry.
That's a good one. I haven't heard that one before. That's good. What else do I need to cover? Everybody got their groups, right? You should be connecting. No, you already turned in your first case study with your groups. And now you should be starting to look at your infectious disease.
I have a quick question, and it may not be one that like you specifically can answer, but I know that like a lot of the anxiety, you may want to call it, with this class is that since we don't have quizzes or an exam for to help with any of those key graded assignments, like to get that extra grade up, and then we have all these assignments and stuff. Has there ever been like a thought about at least making one of the assignments equivalent to a quiz grade so that there is something to help with the key graded assignment?
We haven't had that discussion, Erica. I can certainly bring it up at our next faculty meeting.
I mean, we know like all the other classes, I think maybe OB or I don't know, only has 3 exams, but even in OB, you still have quizzes.
Right. Well, this class is different. This class is different.
Oh, no, absolutely.
OB.
I get it. That's why I was just curious. Like,
yeah.
Have you ever thought about not doing so many assignments and doing like at least making it a quiz grade?
Yeah. I mean, that's excellent input. I'll take that back to the team. But yeah, this class just has 3 exams and a Hesse for your key graded assessments, and all 4 are worth 20% each. So that's why I say if you score low in exam 1, you're just playing catch up. So anyway, well, please reach out to me if you'd like to review the exam. If you're having conflicts with all of those times I sent, let me know and we'll try and work something out. Like I said, this week is a super busy week for me covering the other professors' classes, but I will be happy to work you in early in the morning, late at night, whatever works for you guys. Okay, I'm here to help you. And the exam review is for you. Okay. I didn't have I only had 3 students attend any of the live reviews. I had 3 students. And one of the students attended, I think, all of them. And the other 2 students attended 1. So, like I said, I know you guys are busy, but we do try and be flexible and offer them 4 different days, right? Thursday, Friday, Saturday, Sunday. So, and I think I told you guys in week 1, there is a direct correlation with attending live reviews and increased exam scores. So only 3 of you attended. I hope you guys watched a recording. Did you? Most of you watch a recording?
I watched recordings.
Okay. 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 All right. Any other questions before we get going? Okay. So we're in week 4. We'll start at week 3. Our week 3 readings are, let's see, we're going to cover rural, chapter 24, chapter 25, which is poverty, homelessness, teen pregnancy and mental illness. And then 26 is alcohol, tobacco, and other drugs. So we'll go through that quickly.
I'm sorry, real quick. Have you read all those books behind you?
That's like my virtual background.
Oh, I'm sorry.
Yeah. If you were to see my background, you would belly laugh.
Oh, I'm sorry. I was just looking at all those books.
They look cool though, don't they?
They do. I'm sorry to interrupt, but I'm sorry.
It's okay. It's all right. So we're going to cover those 3 chapters from your 6th edition. Everything's working out with the 6th edition, right? We have already updated all the information we're sending you, so you have all the updated chapters, correct? And are you guys reviewing PowerPoints? Because the expectation is that you review the PowerPoints prior to coming to class, so at least we know what we're covering. And then we kind of go into the book and PowerPoints and all that. And then everything's connected. The PowerPoints are a summary of your readings and your assignments. Okay. So we already did the attestation. You guys already turned in your case study. I'll be grading those probably all day tomorrow. We had the exam. Okay, so week 4 this week. We're going to be covering chapters 4, 29, and 30, which is government and healthcare, faith community nurse, and home health and hospice. Okay, and let's see what our attestation questions are. Okay, so what are the 2 parish-based modules for faith community? We'll get to that. And then the 5 practice models for home health and hospice. So we'll get to that. Okay, and then the last, let's see. Has everybody, if you shouldn't have any problems accessing your case study, there's a link to it right on the hospice case study. It's right on the page, right in your module. So please do that assignment from your module. Okay. All right. Let's like to go to the textbook.
I just have one quick question.
Yeah, of course, Robin.
I was looking at what you put down for the week 4 information to be prepared. So we're supposed to choose our infectious disease with the paper or that's due in week 7 by the end of this week.
It would be helpful
Okay.
if you could. Let's see, next week's 5, so it's probably going to take a couple of weeks to do it, but it would be helpful to have it by the end of this week. And the reason
why,
just
email that to you.
Yeah, so just one
Do
person.
we all individually have to email it to you?
No,
I was just like one person email it and say.
Hang on, Erica. I was just going to say that.
Sorry.
I was going to say I need only one person from each group to email me what topic you're covering, and that's because I want to try and spread it out so we don't have 4 groups doing HIV, because that's not going to help you guys when you're doing peer responses. You get to at least view all the different topics. And I think we have 6 groups. So one person, if you could just email me what you guys want to do. And I believe there's a link. I think we go to the CDC website under infectious diseases and pick a topic.
And are these going to be different groups than last time?
Nope, they're all the same. That was in the announcement. These groups will be the same for both assignments. And the purpose of doing that, Megan, is because group dynamics are super important. And if there were, say, issues, during the first group assignment, then hopefully they can get resolved and the second group assignment goes a lot smoother. Does that make sense? It's working in a team, working in group dynamics, knowing how to problem solve issues that come up. And for example, let's say there's a student that didn't participate or didn't do their fair share. Hopefully the other group members speak constructively to their teammate and let them know that they were disappointed or they didn't feel like they carried their load, and that going forward, this is the way we're going to be doing the next assignment. Okay? Does that help, Megan?
Yeah, that answers the question. Thank you.
You're welcome. You're welcome. Okay, so let's get into, I'm going to do last week's lecture from the book. A lot of great information in the book. Okay. So what do you guys think about when you think about the rural health, rural community, rural clients? I'm okay
Lack
with
of resources.
To healthcare.
Lack of education.
Yeah. What's the difference between rural and urban?
Rural, there's not as many people. Urban is there's more people.
Okay. I don't know if you guys have figured this out yet, but your chapter outline, we developed the PowerPoints from your chapter outline. Okay. And then your chapter outline is obviously a summary of the chapter. Okay. So let's go through this. Okay. Then the expectation is that after each class, whatever week it is, you'll be able to articulate the objectives. Right? We've already talked about that, right? So by the end of week 3, you should be able to compare and contrast your rural versus urban, describe health status of rural populations, and so on. Okay, so that's the expectation, is that you can articulate, compare, describe, discuss, whatever it's asking you to do. Okay. And then here's some key terms. And you guys have probably already figured out that if you want the definition of rural, you can just click on the word, right? And it gives you what the definition, it takes you right to the page. Okay. Okay, what do we know about rural? Well, what we know is a lot of it includes farms. Rural can be a small village, a farm, it's a lot of places where farmers or employees rely on migrant workers to do a lot of the work, right? Whether it's harvesting their crops. Okay. So what kind of health challenges do you think rural community clients face?
Transportation.
Transportation's a big one. What else?
Clean water.
Yep, that's a big one. What else?
Exposure to chemicals.
Pesticide exposure.
And insufficient nursing staff.
Pardon me?
And insufficient nursing staff.
I'm sorry, Stephen, say that one more time.
Shortage of staff.
Oh yeah,
nursing.
Workforce issues. It's really hard to recruit to work in rural areas. And think about it, if you're the nurse in a rural area, you're probably doing most everything, right? If it's a small area, you may be covering a couple of different towns. You may be the infant nurse doing well visits. You may be the pediatric nurse, adult healthcare, elderly healthcare. Rural requires, it's a very, very big scope of care. Okay. I'm just going to skip through a lot of this. We're not going through the whole chapter. Box 24.1 is a good box to review for you guys. Okay. Just gives terms and definitions that you will see or hear described in the rural community. Okay, and here it describes rural as communities having fewer than 20,000 residents or fewer than 99 people per square mile. Okay. Okay, what are some population characteristics and cultural considerations One of the big things we find in rural healthcare is language barriers, right? We have people coming in, whether they're migrant workers or seasonal workers. And think about it. If you have a language barrier issue, how are you going to explain? How are they going to explain to you what's going on? How are you going to be able to do your assessment? Okay. Therefore, they will avoid getting health care. Okay. The rural community has higher poverty rates. Okay, so I'm on page 422, and we need to know this group of 9 characteristics. Higher poverty rates. Rural community is much higher poverty rates than their urban counterparts. Okay, there's lots of different cultural and social norms about health behavior. You may be dealing with many, many different aspects of the population. Okay, or different populations, from Native Americans to African Americans to lots of different minorities, lots of migrants coming in. And so how do you know what their cultures are? How do you know what their beliefs are?
So you want us to know that whole box?
I think I just
I'm
said,
just clarifying what you said.
I said I would like for you to know these 9 characteristics. I didn't talk about a box.
No, when you were talking about like the Native Americans, the migrant farmers, it's further up, like down, but.
I was just giving you examples of number 2.
Oh, okay. Okay, sorry.
Pardon me?
I said, sorry, I'm a page ahead of you, so.
Okay. A lot of times with rural clients, you will find low health literacy levels, and they don't have a good perception of health. And we talked about language barriers. They certainly have limited, affordable, reliable transportation, which has already been brought up. Unpredictable work hours and unemployment. Unemployment is very high in the rural communities. Okay, lower population densities for programs. I mean, lack of access. Okay, that's number 8, availability of resources to support personnel, use of facilities, and effective program operations. That's your hard to recruit areas. And a lot of times, rural clients, a lot of them are hourly based employees. Okay, so what happens if they have a wife who's pregnant and it's a complicated pregnancy, and they have to go down to the cities or the nearest hospital to get high risk OB care? What happens? They lose their day of pay. You know, a lot of these rural jobs do not come with health care and dental care and retirement benefits and paid days off. It's another challenge. Okay, lack of access to healthy foods and physical activity options. A lot of rural community is sedentary. Okay, big problem in the rural community is obesity. Okay, they don't choose to go to primary prevention screening or do screenings. Okay, so a lot of times in the rural community, because they're not doing primary care, when they're diagnosed with, say, diabetes or hypertension or cardiac disease, they're typically diagnosed at the more advanced stages. Okay. And then box 24.2 is good box 2. It's characteristics. Already talked a little bit about this, but greater distances between residents and services, seasonal workers. One of the big issues is lack of anonymity. Okay, lack of anonymity is big in the rural community. And what do we mean when we say that? What happens?
Everybody knows everybody's business.
Yeah, okay, yeah.
Bingo.
Okay.
Everybody knows everybody's business. So a lot of issues are not brought to the attention of a primary care until it's at a crisis level. And those kinds of things are violence, abuse, domestic abuse, sexual abuse, child abuse, mental illness, substance abuse, alcohol abuse, much more high-risk occupations, farming, high risk. Okay. So despite the significant number of people who live in rural areas, their health problems and health behaviors are not fully understood at this point. But we know that in general, they have a much poorer perception of their overall health and functional status than their urban counterparts. Okay. One of the other issues in the rural community is there's a real lack of access to specialty care. So if you've been diagnosed with cancer and need radiation or chemotherapy, you're likely going to the nearest regional hospital. There's a huge lack of oral care, dental care. Okay, they just don't have the facilities and the staff to provide it. Very much higher infant morbidity and mortality rates than your urban counterparts. Does anybody have any experience in the rural community, whether they grew up there or they live there now?
I grew up in a very rural community.
Me too.
Is this sounding familiar?
Yeah.
Yeah.
Would you like to add anything?
No, I think for me that pretty much says it, all that you said. That pretty well sums it up.
I don't know. Yeah, where I grew up in Colorado and Rangeley, the closest physician was 2 hours away in Grand Junction.
Yep. I had to go last summer. I had to travel, so I had to get a COVID test somewhere, and Tom and I split our time between Colorado and Northwest Wisconsin, and I had to drive 2 hours to get a COVID test. There wasn't anything. I checked with all the local public health departments. They didn't even answer the phone. Really rural. I had to drive 2 hours to just get a COVID swab. Just not a lot of.
Yeah, it was like my best friend, her daughter has Rett syndrome, and they have to drive like an hour and a half for her physical therapy. To go to her like specialty doctors, they have to go all the way down to Ann Arbor or Flint, depending on which one, sometimes Detroit, and it's like a 3-hour trip. Yeah. Even to when she has seizures or something and needs to go to the hospital, it's 3 hours.
Yeah. Yeah. It's tough. Traveling time is an issue. Lack of transportation is an issue. Lack of specialty providers is an issue. And when you combine all that with not taking your health, not seriously, but not being as engaged in your health as you should be or your urban counterparts are, it creates a lot of health issues. One of the biggest issues in the rural community with healthcare, with health, is chronic illnesses. Okay, chronic illnesses is huge in the rural population. Okay. And we talked about women's health and maternal infant health, right? Overall, rural populations, as I stated, have a higher infant and maternal morbidity and mortality rates. Okay. The other thing that was sent to you in your PowerPoint that I encourage you to do. This is this check your practice. This is this just a scenario, okay? But we send you the answers to them, so you don't have to pull them up and evolve. But this is a good self exercise, self practice exercise if you'd like to do it. Okay, and in the health of children, there's some big differences between the health of children in the rural areas and the health of children in the urban areas. Okay, they're less likely to see pediatricians and more likely to see, say, a family doctor or a general practitioner, right? Kids that work on the farms are exposed to, one of their biggest risks is exposure to pesticides. Okay. Mental health is a huge issue in the rural communities. Up in Northwest Wisconsin, I had to go and get some fingerprints at the local police station, which was 45 minutes away, and to get one Pennsylvania license, nursing license. Anyway, went in and nobody was around, had to ring a little doorbell. It was like the size, it was like a teeny room. Anyway, 2 officers came back, and as they were doing my fingerprints, I said, okay, so I teach community and public health. So what are your biggest issues up here? And the 2 biggest issues they told me, and this is very rural, was mental health and domestic violence. So, right, a lot of stress-related issues going on in the rural community, whether it's living in poverty, job security, hourly paying jobs, not able to take time off if there's any difficulties, right? Depression because of slowdowns in work, okay? Tons and tons of jobs, especially rural jobs, were lost during COVID, okay? Currently, lots of rural families are struggling, okay? We talked about the many indicators in the previous reports of domestic violence and alcohol and tobacco and other drug and abuse in rural populations are also conflicting, right? And here's your anonymity. When people are related to one another, they're less likely to report these behaviors. Okay, tight-knit communities. For all of you guys that are coming in late, if you could please put your name in the chat. That's how I'm taking attendance going forward. Okay. Rural communities ended up being much more vulnerable during the pandemic, just due to the high proportion. The biggest population groups in the rural community are under 18 and over 65. Okay, so rural Americans, especially the elderly, they have higher smoking rates, prevalence of chronic diseases, lower numbers of people covered by health insurance, lack of healthcare professionals, right? Lots of places had to close and lay off people, which limited access even more. Okay. Your occupational and environmental health problems. The only thing I would like for you to take out of this is the most common health issue farm workers face there are 6 of them, okay? But the primary one is pesticide exposure. So you will need to know what pesticide exposure is. What are the acute symptoms? What are the chronic symptoms? Okay, and you can find this right in this area, okay? So please read through that. As always, I like to cover the levels of prevention box in the chapters because they identify the 3 different levels of prevention based on the topic we're covering. So this is related to rural health. Okay, so what is the primary prevention? Teach workers how to, I'm just going to highlight these, what I want you to know. Primary prevention is teaching workers how to reduce their exposure to pesticides. Second, everybody understand why that's primary? Right, we're trying to prevent something before it happens, right? Secondary is conduct screening. Maybe you're screening for pesticide exposure. Okay. And then tertiary, they've already been exposed and they're symptomatic. So initiate treatment for symptoms of pesticide exposure. Maybe nausea, vomiting, skin irritation. So does everybody understand why those are primary, secondary, and tertiary? So we have to have a handle on that. Every chapter has a level of prevention box related to that topic. So as I said at the beginning of the term, you have to be able to apply not only your ADPI, but your levels of prevention to each topic we're covering. Okay. Box 24.4. Okay, important to review, barriers. Okay, we've already gone over a lot of this, but let's review it. Lack of healthcare providers, greater distances, personal transportation, unavailable public transportation, internet, telephone services, outreach services like your friend who has to, you know, PT, OT, speech, whatever, has to drive. And then when you're traveling from the rural areas, there's always weather, travel issues, or can be. Lack of health insurance. Okay, so you guys can go through that. I'd like for you to review this section. And again, we're not reviewing the whole chapter, but I'm trying to point out the areas that we do need to be familiar with to understand the topic of rural and migrant health. Okay. So here's where it discusses migrant, whoops, sorry about that. Characteristics of migrant farm workers. Have a look at that. This is interesting, this box, 24.1. It talks about different populations, farmers and ranchers, Native Americans, African Americans, migrant workers, okay, Native Alaskans and coal miners. And it talks about what their healthcare needs might be and what they're at risk for, okay, and what they might develop. Great information. Migrant lifestyle. Let's review this section as well. Okay. Very difficult. Migrant farm workers often have a very unpredictable and very difficult lifestyle. Okay, so please read through that section. This is another section I want you to review. Issues of migrant health. Talked about that. A lot of it. Inability or lack of knowledge about the services. Maybe they can't afford it. Maybe they don't qualify. One of the statistics that I teach in my other class is that 49% of migrant and seasonal workers are undocumented. Okay, so they are much less likely to go and seek health care for fear of immigration issues, deportation issues, lack of understanding. Okay. This Migrant Healthcare Act from 1962 gave a lot of benefits to our migrants. Okay, so what I need you to know about that is that there is a Migrant Health Act. I don't need you to know when it was signed. I just need you to know that what resources there are for migrants. Okay, and then we talked about dental, other specific health problems, dental disease, right? They don't have dental insurance, behavioral health. Okay. Okay. Talked about depression, anxiety, PTSD. What about veterans? You know, veterans living in the rural communities, they have to travel a long way to get their services. Okay, so substance abuse, we've touched on that. significant source of stress and injuries. Okay, I was coming on our ride home last week, or down from Western Wisconsin to the airport in Minneapolis. We stopped at a little place where I needed to use the restroom. I had never seen it before, and I think I've been in that place a couple of times. Really small, teeny place. Just go get gas and use a restroom. And I never noticed it before, but in the bathroom there was a sharps container. Another risk for migrants is TB. Why is that? Why are they at risk for TB?
Because of the field that they work in.
Okay, and what specifically? Close housing, they're all crammed together in housing, poor water conditions, poor sanitary conditions. Okay, here's an interesting statistics. Latino population. It's 3 to 5 times greater in the rural population. And then have a look at the section of children with migrant workers. Some travel with their families, some don't. Okay, but they want a better future for their kids. Okay, they may look like kids, but I mean, they are working long hours on the farms, long hours as seasonal workers, and we really have to be mindful of their risks. Okay, and here's a list of their risks, specifically to kids: injuries, fatalities, heat and sun, musculoskeletal injuries, pesticides, educational deprivation. Okay. And then the last part I want to cover in this chapter is cultural considerations for migrant care. Okay. What do we first have to do in our initial relationship building with these migrant populations? What do we need to do as nurses?
Build a rapport?
Exactly. Build a trusting relationship and be culturally competent. What do I mean when I say culturally competent? Okay, we need to be mindful and ask questions about their culture and how they view healthcare and how they expect to be treated. Okay, because each culture has different expectations. Okay, because most of the migrant and seasonal workers are of the Mexican descent, the rest of this section focuses on the Mexican cultures. Okay, so that's important to keep in mind. Okay, so the nurse-client relationship is exactly what we just talked about, being able to respect everybody on an individual level. Everybody has a story to tell and everybody has expectations. Okay, so the relationship building is important. Okay, we have to understand their values, beliefs, and practices. And then here's a summary of nursing care in the rural environments. So please have a look at that section. Okay. The good news is that there's lots of resources, lots of organizations and charities and acts and laws that are working towards better healthcare, better access for rural America. Okay, so this is a good box to review the resources. Okay. What do we know about Healthy People 2030? We need to make sure we have an understanding of what each of the goals and objectives are. in each chapter, just like we review the levels of prevention. Okay, and these are identified based on the topic we're covering. So obviously this is migrant rural life. So the selected objectives pertain to rural workers, including migrant workers. So there's several healthy people, 20, 30 questions on all the exams. And so I don't know how you study, but I would put these healthy people 20, 30 objectives from each chapter on a little index card. Okay. And remember, with healthy people 2030, when you get a question about healthy people 2030, let's say you got one pertaining to rural workers, whatever the question is, these are the only 3 correct answers. Okay. There may be 20 other options that we can think about that would be good objectives as well. Right. And that's fine. But when you're being asked a healthy people 2030 question, it is specific to the information provided in the chapter. Okay. I'm sorry. I take back what I said earlier about the practice, sending you the answers. This is what it's to. It's to the practice application. Okay, so when we send you the PowerPoints, we send you the answers to the practice application, which is a case study. And when it says down here, answers can be found on the Evolve website, we've already pulled those off for you. Okay, so this is a very good self-practice, if you'd like to. Okay. Anybody have any questions about rural care, rural health and migrant care? Okay, chapter 25, poverty, homelessness, teen pregnancy, and mental illness. These are what we consider the 4 most prevalent vulnerable. There's a lot of vulnerable populations, but these are the 4 this chapter covers. Okay, and again, your chapter outline is just a summary of the whole chapter. And then please have a look at your objectives. Okay, that's how we build our study guides, objectives, build exams from all of these things. Tiffany, sorry, you're shaking your head.
Nothing. Sorry.
Your key terms. Okay, so this is kind of taking very similar to rural health as well. We have to understand our vulnerable groups. Okay. So we'll start with poverty. Definition and description. Okay, it gives you what the federal guidelines are. You don't need to know all these numbers. You just need to know how people are categorized based on their finances that are listed at the poverty level. And there's a lot of people below the poverty line. There's a lot of people right at the poverty line. And there's a lot of people, families right above the poverty line. So,
can I ask a question?
Yeah, who's this?
This is Jill. On the next exam, is it going to be 2020 or 2030?
We covered that a couple of weeks ago. Everything's 2030 in your 6th edition. There was one question that ended up not getting changed on exam 1. Is that why you're asking that?
Yeah. Okay. I mean, from here on out, is it going to be 2030?
Yes, it will be.
Okay.
Thanks for the question. Okay, people who live in poverty are from all walks of life, right? It's important to listen and understand people's stories. Okay, poverty, really the definition of poverty is having insufficient resources to meet your basic living expenses. Okay, and we consider basic living expenses as food, shelter, clothing, transportation, and healthcare. So if you're asked a question about what areas do we look at when we define poverty, not so much the finances, what else? Okay, not able to meet your basic living expenses. We're referring to food, shelter, clothing, transportation, and healthcare. I'd like for you to have a look at this list. We know that poverty is a very complex issue, has many moving parts. Okay, here's a list of factors that affect the growing number of poor people. I know during the pandemic, when I was in the schools for 2 years, during the pandemic, we saw a dramatic increase in the number of families who went from above the poverty line to below. And we also saw a dramatic increase in the number of homeless families. Parents lost their jobs. Parents had to quit their jobs to stay home with the kids. So anyway, here's some factors that affect poverty. Okay, so please be familiar with this list, okay? How does poverty affect, how does it affect across the whole lifespan? Okay, higher rates of chronic illness, higher infant morbidity and mortality, life expectancy, shorter, much more complex health problems again, like rural. It might be an access issue. It might be a health insurance issue. Okay, and if they're not seeking out primary or secondary interventions to either be preventative or screen for being at risk, we usually see them in the tertiary stage, which is they already have complex health problems. Okay. Hospitalization rates are greater for persons with higher incomes. Okay. Hospitalization rates for people in poverty are much higher than people with higher incomes. Okay. Already talked about all that. Poor health outcomes from poverty are consistent with those in the rural and migrant populations that we just discussed. Poor health outcomes are often secondary barriers that impede access. The ability to pay for it, healthcare, lack of insurance, geographical location, language barriers, transportation. Okay. And then box 25.1, the effects of poverty on the health of kids. Significant. Okay. And here's a list of some of the effects of poverty on children. And of course, it depends what age the kids are and what issues they face. Yes, Tiffany.
So I just have a question before you get too much further into this massive amounts of information. As far as moving forward for the upcoming exams, are you wanting us, and you said it a couple different ways, so I just need a little bit of clarification. Are our main points coming from boxes? Are they coming from the questions at the end of each chapter? Are they coming from the paragraphs in the middle? Are they coming from collectively everything? Because I don't know if it's just me. This is a massive amount of information, and trying to absorb it all is, I don't even know. It almost seems impossible. Unless I can have some sort of tapered down.
Well, I am tapering it down because I'm not covering chapters from front to back. I'm skipping through a lot of it.
Well, that's why I was saying, like, are you wanting us to focus more like on the boxes and know every box like you're pointing out? And please understand, I'm not trying to be rude or disrespectful, and I'm not trying to speak for everybody else. I guess I'm just speaking for myself. I just want to know if what you're highlighting, that's what you're expecting us to know. If you're wanting us, like when you say know this, know that, know this, if that's kind of where it's coming from, is what I guess I'm getting at.
Yeah, where I'm highlighting is what I'd like you to know and read through. Now, have you had the opportunity to read through the chapters, Tiffany, before this class?
Yes, but it's still, regardless of how you read through it, it's a lot of information.
It is.
And we're going back to back.
And we're also covering six chapters today.
Right. That's why I was saying I've had a chance to read through that, but still trying to make sense of it, heads or tails, while coming directly from a PEDS class, while going directly into another class tomorrow. I just want to make sure that I'm using and utilizing the best of my own time to absorb the information to the best of my ability. That's why I was asking.
Okay. So what I'm trying to cover are important aspects of each chapter.
Okay, thank you so much.
I mean, I really, I don't know how to be any more specific than that. I mean, I can't go through and say, hey, know this for the exam. Hey, know this for the exam. I can't do that. So I'm trying to pull out the important parts of each chapter that meet the objectives, actually. Okay. So if you go back and look at your objectives, these are the parts I'm pulling out.
Okay.
So I would say that to everybody, go back to your objectives, and those are the parts we're covering in the book. Okay. Anybody else? Was somebody else that was talking or wanted to say something?
Oh, I was just asking, like, isn't, like, generally speaking, community taught in like BSN programs?
I don't know the answer to that, Erica. Why?
Oh, okay. I'm sorry.
Why do you ask that?
Because she was just talking about, like, to really understand it and then like interpret it and be able to apply it. It is a lot.
I'm sorry. Who was talking about that? What?
Tiffany was talking about she was talking about how much information it is, and like it's kind of hard to like learn it, apply it, interpret it, all of it. And so I was like, it is a lot. So I was just wondering if I thought community was taught in like a BSN program generally.
I thought the same thing.
It is. I know it's taught in BSN programs as well. And that would be a conversation I would probably have with your dean on your campus. Okay. So part of the role as a community nurse is, this is just an overall statement, part of the role of community nurse is taking care of vulnerable populations. Okay, so you really do have to understand what the issues are with rural clients. You have to understand what the issues are with homelessness. Okay, you have to understand what poverty means, teen pregnancy. These are all very prevalent issues in community nursing. Whether you guys are going to be community nurses or not, or whatever kind of nurses, I mean, the community is part of your program. And so what we're covering today are significant vulnerable populations in the community. So for you to have an understanding of what's the makeup of the rural population, what kind of health issues do they have, what are their barriers, that's what we need to know. Poverty, how do people get into poverty? What are their characteristics? What are the risks for kids in poverty? So yes, it is a lot of information, but I'm trying to wither it down for you guys so that we're not covering everything. Okay. And then homelessness is another big, very big problem in community nursing. Very big problem in society, actually. Okay. And then we know poverty can lead to homelessness. Okay. Most people, great majority of people don't want to be homeless. Okay. So what does it take? What does it take for us to be able to care for them in the community? Just a question. So when you're riding the bus or riding your bike or taking a walk or driving through your community and you see a, say, homeless encampment, what do you guys think? What comes to mind?
That they need help.
What else comes to mind?
I don't think it's to that point.
I always think about people having mental illness.
Yep.
I also think that most of them are drug addicts.
Juliana, you home? Welcome home.
Yes, thank you.
Welcome home.
You think a majority of the people in homeless camps are drug addicts?
Drug addiction and substance abuse are very prevalent within the homeless population. That's a fact.
Right, I know that. I just was saying, like, she thought, I was clarifying that she said a majority of the ones that she was thinking were drug addicts. That's why she cut out.
So what I was saying is, what comes to mind at first is, it could be mental health or drug addicts. It's just, my mind just takes me there that some of them could be users. That's what, comes to mind first for me.
Tiffany, do you want to respond?
Homeless veterans who,
I was just about to say that actually homeless veterans are coming up in the numbers too. That's why I was clarifying if she was just saying that's where her mind led directly, or if that's what she was knowing as fact, or just a little bit of clarification. Because we were talking about it in MedSurg the other day about the care, and somehow we got on the topic, and that not all homeless camps and shelters are just specific drug addicts, that the vets right now are a big one.
Like chronic disease, period. Like not just like mental health, but just chronic disease. I mean, job displacement,
disabilities.
I mean, personally,
those are the things I think about when I think like drug addiction and things like that can be a side effect or, secondary to that.
Yeah,
not necessarily like that directly.
No, I think that people get down on their luck and they use drugs and alcohol to escape the situation that they're in a lot of times, and they self-medicate when they do have mental illness, and addiction goes right along with mental illness. So for me, I just think about people that need just need some assistance, basically, some guidance.
Well, there's a lot of, what does it take to care for a homeless individual or homeless family? It's a multidisciplinary, really integrated approach. Okay, it takes people that really do understand what the homeless population is all about and what they're going through, right? Whether it's it's just a whole team of people. I know when I drive by and see employees or workers out on the streets trying to work with these families, trying to establish trust and establish a relationship. So mom feels comfortable going into a doctor's, clinic with her 3-4 little kids and maybe get some immunizations, maybe get a physical, whatever. I mean, there's a lot of issues. I mean, yes, there's a lot of individual issues with domestic abuse and violence and drug addiction, but everybody got there in a different way. And so it's important to recognize that's what happens when you try and work with the homeless. You try and establish, how did they want to tell their story? How did they get here? Establish trust, always have empathy and compassion. Most don't want to be where they are. And the other real challenge with homelessness is the families. You know, kids at all different ages have all different reactions and all different risk factors to homelessness. Okay. Like you guys just said, somebody pointed out, many homeless people were mentally ill before becoming homeless, right? Where others develop mental illness because of being homeless. Is that what you're saying, Erica? Did you say that? I can't remember.
Yeah, I mean, that's what I was going, you know, like you're talking about like the mom and the kids going to the clinic, like there's 1,000 different ways they could have gotten there. Their father or husband could have been abusive, like the children
Sure.
have chronic illnesses and they can't afford healthcare for themselves, let alone their children. So they, you know, mortgage their house and their cars, and that's where they're at right now.
Exactly. I remember during the pandemic, we had lots of new families that were living in their cars. They lost their homes, they lost everything. Okay. Veterans, we talked about. Veterans are another high-risk population. Okay. Then the effects of homelessness on health. Probably pretty self-explanatory in these bullets, right? Maybe hypothermia or heat-related illnesses, extreme sun exposure to cold exposure. Okay. Skin integrity, infestations of whatever, bugs, scabies, lice. Okay. Also, homeless people don't have access to dental care. Okay. And here's a nice summary of the homeless and at-risk populations. Okay. They do go through a section of adolescent sexual behavior with regards to homelessness, or I'm sorry, with regards to teen pregnancy. Okay. Why is teen pregnancy a vulnerable population? Okay, I'm going to have you read through that section because you have to be able to answer that question. What are the risk factors? What do they lack? They lack prenatal. What are they at risk of? Not going to prenatal visits, substance abuse, drug abuse during pregnancy, unintended pregnancy, unwanted pregnancy. Okay. Okay, I'm going to skip to chapter 26. Oh, that's not what I wanted. Definitely not what I wanted. Sorry, I lost my book here. Have you guys dug into this Calculating with Confidence book? No.
We had it a few terms ago.
Yeah, it's a really good book that can be used all through your program. Okay, let's go through chapter 26 rather quickly. This is, again, more vulnerable, more issues with the vulnerable populations. Okay, alcohol, tobacco, and other drug problems in the community. Let's start with your objectives. That's what we're going to cover. Okay, what's the difference between substance abuse, dependence, and addiction? What are some examples of the major psychoactive drug categories? What are depressants? What are stimulants? What's marijuana? What's hallucinogens? Okay, so start with your objectives. That's what we need to know out of that chapter, Tiffany. That's specifically what we need to know. Lots of key terms in this chapter. Okay, so if you read the objective and it says, what's a depressant? What's a stimulant? What's marijuana? What's a hallucinogen? Hallucinogen. You can right here, depressants, 457, just click on it. Okay, so read your objectives. Okay. Right, we know substance abuse, leading national health problem, or causing more deaths and disabilities than any other health condition. Okay. ATOD means alcohol, tobacco, and other drugs, just so you know, right? It can cause multiple health problems for individuals, right? Many reasons. Lack of knowledge, a bad drug they picked up on the street, illicit drugs, family history, peer pressure, you name it. Here's your definitions. This is one of your objectives. What's the difference between dependence, addiction? Okay, this is right here on page 467. Okay, so that's where it answers that objective. Okay, and then it goes through what are psychoactive drugs, what are depressants, what are stimulants, energy drinks they talk about, alcohol, right? Alcohol is the oldest and most widely used psychoactive drug in the world. Okay, as many as 40 to 60% of alcohol related disorders is potentially genetic. That's a lot. And then we know that alcohol abuse causes billions of dollars in lost productivity, property damage, medical expenses, and so on. Okay. Tobacco. Okay, tobacco, big issue. All right. And then here's a few others: caffeine, cannabis, opioids. Okay, so basically what you need to know is the different kinds of drugs. What's considered drugs that we abuse. Okay. Drug education. So here's where we come in. What can we do to help? Okay. Drug education, primary prevention. Now I did that all throughout the schools. Okay. What's the chemical in the drug? How do we, this we teach the kids. You know, actually we're down at elementary school. Educating the kids on the risks of drug abuse. Right, and here's our role. Okay, there's our role. And here's our levels of prevention box, okay, related to alcohol, tobacco, and other drugs. You can read through that and let me know if you have any questions. You should hopefully understand why each is primary prevention, secondary screening, tertiary. We're helping people who are already addicted or have substance abuse issues. Okay. That's all I wanted to cover for this chapter. Okay, so again, look at your objectives, be able to answer those. If you can't answer them, then you'll have to go back into the chapter and find where that is. Again, the PowerPoints are helpful. It's all connected. It's all connected. And then I'm going to, let's see, chapter 4, there's really not much in. It's the government, the law, and policy activism. It's only a few things we need to know from this chapter. Okay. Okay. 6 objectives. Okay. I know you guys are tired. I'm trying to get through this. Okay. The big department we work under, and we all are under, is the Department of HHS. Okay. Government is involved in many different ways. Okay, they're involved at the federal level, they're involved at the state level, they're involved at the local level. Okay. Government healthcare functions. So we're doing federal, state, and local governments carry 5 healthcare functions that fall into general categories. Okay, it'd be helpful to know these categories right here. Okay, I'm on page 60. Okay, it's important to know what all of our federal, state, and local groups, the 5 healthcare functions that they help us function within a community: direct services, financing, information, policy setting, and public protection. Okay, and then it goes through each one. All I need you to know are what is their 5 functions. Then the rest of this goes through each of them. Okay, you don't need to know all of that. You just need to know what the 5 functions are. Okay, and this is great. This is a comparison of healthy people 2000, 2010, 20, and then healthy people 2030. And the purpose of looking at this box is to see how goals have evolved. Okay, so for example, back in 2000, when increased the years of healthy life, okay? 10 years later was increase the quality of years of a healthy life. Just became much more detailed. Then in 2020, it became attain a higher quality, longer life free of preventable disease. So this is all the same goal. This is all right here. Just started out like this. So this is the purpose of this visual. Okay, and again, we still have more detail over here. Okay, so make sure you're aware of that. And the point of mentioning this is how things evolve. They become more detail oriented. They expand. Just instead of preventing a disease, not only that, we want to attain a higher quality of life, preventing for us from getting any diseases. Okay, here's some organizations the government uses. So just what I need you to know about the World Health Organization is it's an international organization. Okay, they're international. It's the only international organization we discuss in this class. Okay, and this is what they do. Okay, their goal is to make sure that everybody in the world's healthy. That's their goal. How do they do it? Here's some bullets. Okay, so it's the only international federal agencies. Okay, at the top is our HHS. Okay, and then there are some other administration, there are other branches of HHS that fall under them. Okay, and there's a few that you need to know the name of, or you need to know what they do. Okay, and it's the first sentence of the paragraph. Okay, so the Health Resources and Services Administration, they're trying to improve the health of Americans by educating teachers, educating professors, educating, that's what they do. Resources and Service Administration. That's one we need to know. Second is CDC. Okay. CDC has been our go-to for the last 2.5 years. Okay. Okay. And again, their first sentence is what they do. So if you get a question that says, this governmental agency, let's see, this governmental agency applies disease prevention and control, environmental health, health promotion. Which is it? Is it HHS? Is it CDC? Is it WHO? Okay. And then the NIH, we've heard about that over the last couple of years. What do? They're biomedical research. Okay, that's all you need to know about them. And the Agency for Healthcare Research and Quality. Okay, there's agency charged with improving quality and safety. Okay, so these are just one-line definitions of what each of them do. Okay, and then last is the Center for Medicare and Medicaid. Okay, this is the public insurance system. Okay, we don't need to know any of these other departments. We do need to know this part. Laws specific to nursing practice, right? We all have our code of ethics. We have our scope of practices. School nurses have their own scope of practice. Hospice nurses have their own scope of practice. Home health does, occupational health, faith community. Okay. That's what you need to know, is that we all have our different scopes of practice. So I'd like for you to read through this section, scope of practice. Okay. And then professional negligence. What is this? Okay. Okay. Malpractice is defined as an act, intentional or unintentional, leads to an injury. Okay. So here's what we need to know about malpractice, negligence. Okay. To recover any money damages, all these four have to apply. Okay. So that could be a select all that apply question. When we're talking about professional negligence, what has to be proved? Select all that apply. There's 4 things. Okay, page 69. And then, of course, we play a role in the policy process if we choose to be involved. In community nursing, public health, we're very involved in process. Developing new policies, laws, providing feedback to our local politicians of bills and acts and legislation. School nurses here in Colorado are very involved at the Capitol, very involved with school health. Okay, so that's it for that. And then the last 2 chapters I'd like to cover are faith, community, and home health. So when you guys think of faith community nursing, what do you think of? Anybody know a faith community nurse?
Isn't that the parish nurse?
Me of religious.
Yeah. Yeah. Hang on, I'm too far ahead here. I'm trying to get to section 7. Faith community nurse. So right, it's a parish nurse, right? That's interchangeable. Parish nurse, faith community nurse. Okay. So again, have a look at your objectives. Okay. Same, the faith community nurse is a licensed registered nurse, right? Most of what faith community nursing does is educational and supportive. And what's different about it faith community nurses, it brings a spiritual aspect of care into caring for the client. Okay, there's two models of faith community nursing that we need to just know the differences of. Well, here's a good list if you want to just have an idea of what nursing interventions faith community nurses might do. Here's a list of what they might do. Okay. So you have to memorize this list at all, just if you want to have a better understanding of the functions or the tasks they may perform. And with faith community nursing, they're under whether it's a church, whether it's a mosque, whether it's a temple. When we refer to faith community nursing, it's whatever faith you practice or whatever faith is in the community. Okay, so you may be a faith community nurse at a particular place, but not attend there. Okay, but you obviously would have knowledge of their practice and their beliefs. And typically faith community nurses are under the guidance of the governing body of the parish, mosque, temple. Okay, holistic, whole person care, holistic care, spiritual care. Okay, relates to the relationship between the body, mind, and spirit. All right. And so faith community nurses go beyond by just seeing the patient as physical. Okay, then she's supported by the congregation. She does the nursing process, obviously, assesses plans, implements. Okay. Here's what we need to know the difference of. What's the difference between religiosity and spirituality? Those are two terms that you need to know from this chapter. So spirituality is the big picture, okay? That's your overall attitudes and beliefs related to transcendence or the non-material forces of nature. Okay, religiosity refers to a specific belief and behaviors associated with a specific religion. Okay, so we do need to know the difference between those two. Okay. Okay, here's our levels of prevention. This is a good one. This is a good box. This gives you several examples in each. So have a look at this, please. Page 523. Okay, and you should have an understanding of primary, secondary, tertiary. If you don't, you need to let me know. Okay. This goes through there's additional education requirements and continuing education requirements for faith community nurses. Okay, so characteristics, the spiritual dimension is central to the practice. Okay. This is why that extra education is required, because your care involves humanities, theology, because you're bringing the spiritual piece into it. Okay. So that's the characteristics. Trying to get to the two models here. So as you can see, I'm skipping over a lot here. Okay, models, there's two models. That we need to understand. One is the, it's not in this section. One is the congregational model. This is one of the attestation questions. I'll find the models in just a minute. I just want to keep going here. Here's your Healthy People 2030 goals. Okay, so if you get a question about what are Healthy People 2030 goals with regards to faith communities, these are your right answers. Okay, I can't find my two models here. Well, I know where I'm going to go to find them, to get right to them. Education models. Probably just went through that. So there's two types of models. One is the congregational model, and the other is escaping my mind, but it's when you go outside. I'll find it for you. That's our attestation questions. The congregational model is when you're just functioning within your congregation. Oh, the other one is institutional model. Congregation model, institution model. Congregation, you're just functioning within your congregation. You're just taking care of, whether you're doing home visits, new baby visits, well visits, you're just taking care of people in your congregation. If you move outside and your congregation contracts with other services, say urgent cares, hospitals, transportation, physical therapy, those kinds of things. Okay, that's a more integrated. We're partnering with the community. Okay. Okay, so here's your congregation model. Okay, so we do have to have an understanding of that. Okay. So one is functioning within the community and one is partnering with the community. So if your congregation decides, the governing body decides, you know, we want to be able to take our people in our congregation to their doctor's visits. Then they set up a partnership with the rides. Does that make sense? So those are the two differences. Okay. Or those are the two models. That's all we need to know from that chapter. Okay. So again, look at your objectives. And then the last chapter to cover is public health, the nurse in public health, home health, palliative care, and hospice. This is all covered in one chapter. Okay. So public health home health and hospice health have a lot of similarities. Obviously, hospice is palliative care, right? So public health, home health, hospice, palliative care, they all fall under the umbrella of public health, community-oriented, and population-focused practice. Guys, remember those terms from week 1 and 2? Okay, they do practice their ADPI, obviously. Nurses practicing these specialties provide comprehensive planning, assessment, intervention, evaluation. Okay, so again, we're using our ADPI, nursing process. You're using it in the hospital, your clinical settings, and then we use it differently in the community setting. So the ADPI will look different for a home health nurse. It will look different for a hospice nurse. Okay. And this is who your team might be. Home health, hospice, and palliative care. This is who your team might include. Nurses, social workers, PTOT, aides, LPNs, chaplains. Okay, it's collaboration. It's all about collaboration when you're doing public health in the community. Okay, what are the goals? Improve the health of populations, try to enhance the experience of care for individuals, and reduce the cost. We're doing more. I mean, 10 years ago, 15 years ago, so much of what is done in home health and hospice care was done in a hospital setting. So much has moved to the community. Okay. Levels of prevention. Again, with related to home health. Whoops, sorry about that. Home health. Okay, so we got to know this box. So here, this is your other attestation questions. What are the 5? Who's on there? What's the second attestation question? The first is, what are the 2 different models of hospice nursing? What's the second question?
That's the 5 practice models for home health and hospice community nurse.
It's right here. So if somebody wants to put that in the chat now, that's going to be the answer to our second question. Okay. And hospice and palliative care. Okay, again, they have their own scope of practice, right? Obviously, it's client focused. Of course, you have to bring the family in, but it's primarily client focused, holistic. We're trying to evidence-based practice, meaning our best practice using our current research and knowledge. Ethics is huge. Communication skills is huge. Interprofessional collaboration. How do you pull in family members that aren't on board? Okay, how do you coordinate care coordination? Right, and then you're focusing on transitions of care. You know, maybe you've gone from a hospital to a long-term care, or you've gone from a hospital to a rehab, to an assisted living, to a long-term care. There's a lot of coordination, right? And obviously with hospice, symptom management, pain relief, and comfort. Okay. Again, there's your team, hospice team. Okay. And this talks about the scope, the different scopes of standards of practice. And we can skip through all this. Okay. I think that's it in this chapter. This is for you as nurses, this is an excellent box to read as well. Nothing that is mandatory to know, but really interesting read. It's an interesting read. Factors for successful interprofessional collaboration. This is what I was somewhat alluding to at the beginning when we were talking about group dynamics. Okay, your nursing career is all going to be about interprofessional collaboration. It just is, unless you're working out by yourself on an island. Okay, it's key to your career. Okay, so, and then with any, my last point, with any, whether it's school nursing, whether it's faith community nursing, whether it's home health, palliative care, There's always going to be legal, ethical, and financial issues with each of them. And that's simply what I want you to know. Okay, with every different scope of practice, every kind of community nurse, you're always going to have legal, ethical, and financial issues. Okay. Here's your Healthy People 2030 box for this chapter. Okay, what are the national health objectives for the year 2030? Okay, there's 7 of them. So again, if you get asked about this, these are the correct answers. A lot of my students just go through the chapters and put these on cards, right? So for exam 2, you would have 3, and I'm not sure how many chapters we're covering next week. 3 maybe. So you'd have 9 cards with Healthy People 2030 objectives. Okay. Okay. I know you guys are exhausted. Try and get you out a few minutes early. If everybody could pull up their attestation, that'd be great. Okay, and who wants to answer the first question?
I already put it in the chat.
Oh, Tiffany, thank you. Well, the first question, did you put the first one in there too?
Mm-hmm.
Awesome. Starla, I don't understand your question. So we profiling, or is that what you're suggesting? I'm sorry. Starla?
It was a long time ago about the homeless people being drug addicts and stuff. I lost you, but it's okay.
I certainly wasn't intending to profile. I didn't come across that way. It's just discussing issues that homeless people have. Did I come across that way?
No, it's fine. Like, I thought that you were saying, like, basically when you look at the population, like, you're supposed to just profile them based off of what they look like. But it's fine. Don't worry about it. It's over. I understand what you were saying now.
It looks like we have the answer to the second question. Who wants to take a stab at the first question? Which are the 2 models? Isn't it, what are the 2 models of faith-based nursing?
They're both in there. It says number 1, which is spiritual care and health, behavioral health, and then the second one's listed directly behind it.
Okay, and actually, that's not correct for number 1. The question is asking you what 2 models, and the 2 models are, well, congregational model and institutional model. So once you guys finish that, if you could just hit submit and then your attestation is done. And then I guess 10 minutes early. So I hope you guys get some rest, and we'll see you next week. And if anybody wants to do an exam review, please sign up for those times and let me know.
So what's the answer for number 2 for the attestation, please?
It's in the chat.
Oh, I see. Okay. Spiritual care and behavioral health.
Yes. No. It's
the other one, Tech. Brittany put it in there. It's population focused healthcare, transitional care, home-based primary, and home health and hospice.
It's not fun. It's not fun because I'm not
Oh.
doing anything.
Oh, I see. Thank you.
I put 1 and 2 in there, but 1 is wrong.
No worries. I just wanted to clarify it.
I just put 1 below you guys. So I think that's what it is for 1.
Well, I hope you guys have a good night. It was good to see everybody tonight. Please reach out if you need anything, okay? And I'll stay on after if anybody has any questions.